Right, good afternoon, everybody. For those of you that weren't able to get to the last talk, my name's James Bettridge-Sorby. I'm a GP partner in Swadlincote, but I also do some work around LGBT plus health issues. This is the second of the LGBT plus strand of talks that are being done as part of the Lunch and Learn series through the GPTF. And today we're going to be looking at clinical aspects of care for LGBT plus patients. So what I want to go through is just a little bit of an introduction to the session, outline what we're doing today, and also a future session, because this is talk 2 of 3 in this LGBT plus strand. I'm going to cover some screening issues, gender dysphoria, fertility support, and just do a little bit of an update around sexual health promotion, PEP, PrEP and HIV, and a little update on monkeypox as well. So for those of you that were here last time, I said that I'd been doing some work with the RCGP. Just prior to the pandemic, we formed a small working group within the Royal College of GPs, looking at how we can best support LGBT plus patients, but also provide support for LGBT plus staff members working in the primary care environment as well. And in doing that, the group of us that got together, which were a range of GPs from the LGBT plus community, we were drawing on not only our own clinical experience, but also what experiences we'd had of primary care as patients ourselves. So very much looking at both aspects of that. For those of you that were here last time, and for those of you that weren't, the talk's available on the GPTF YouTube channel. Last time we did an introduction to LGBT plus health in primary care, where we looked a bit at the history of LGBT plus rights in the UK and the terminology that's often used, looked a bit at population statistics, health and health-related behaviours of the LGBT plus population, looked at health inequalities, and also ended with a case discussion. As I've mentioned, today we're looking far more at the clinical aspects of those areas of care, and particularly what I thought in the time allowed tend to be kind of the sort of main issues that perhaps GPs sometimes need a bit of help with around sort of screening, the health promotion side of things. Gender dysphoria is obviously a very big political matter as well at present, fertility support, and as I say, kind of a bit of an update around sexual health where relevant to LGBT plus patients. And the future session, which is due to take place on the 31st of August, that's one which is more about supporting your own practices and workplaces and LGBT plus staff within them. So the next session is going to look at visibility within your organisations, a bit around coding, some accreditation schemes, and further learning opportunities that are available for practices. But I'll also touch on things like HR considerations within contracts and partnership agreements, and what wellbeing support there is specifically for LGBT plus staff. So if we start by thinking about the cancer screening programs, obviously kind of there are a number of cancer screening programs within the UK, and the vast majority of those relate to patients' biological sex and the gender that is recorded on their NHS record when it comes to recall. And what we know is that it's a pretty consistent finding that the LGBT plus population experiences significant health inequalities, including their participation and uptake of those national screening programs. And what I hope the next few sort of slides will do is just sort of make you think a little bit about what sort of strategies you might want to employ for making your own sort of practice and your own clinical practice more effective in supporting LGBT plus patients in accessing the various screening programs that are available to them. So if we think about a sort of a typical case, Helen. So Helen's a 32-year-old woman. She takes a progesterone-only period, progesterone-only pill rather, which she finds helpful for her heavy periods, and smokes around 10 cigarettes per day. You're reviewing your QOF register, and it highlights that Helen has never had a smear test. And when questioned about this, she states she's been told that she doesn't need one because she only ever has sex with other women. And how might we respond to that? And so I'm sure, kind of the vast majority of 99% of cervical cancer is caused by the human papillomavirus. And the human papillomavirus prevalence in women who only have sex with other women is still present at about 13%. And it's worth bearing in mind that the human papillomavirus is also causal in other cancers too, including anal cancer and the squamous cell cancers of the head and neck. And when we think about different types of intercourse, we know that genital touching, oral sex, and shared use of sex toys can all be routes of transmission from one individual to another of HPV. As we spoke about last time, lifestyle factors such as smoking were more prevalent in lesbian and bisexual women. So we've got another risk factor there. And I think it's important that where people are eligible, we also offer catch-up HPV vaccines, because obviously the HPV vaccination program has been going on for a while now, and there may well be women who you come across who perhaps haven't been vaccinated and are eligible for catch-up vaccination. In Tom's case, we can think about Tom as being a, that shouldn't say 5-year-old, it should say 25-year-old trans man who had top surgery. So that's what we call chest wall contouring 2 years ago. He's never had cervical cancer screening and won't receive breast or cervical screening invites. So if we think back to our sort of session last week, if Tom's a 25-year-old trans man, that means that biologically he was born as a woman. He's had surgery to his breasts, but having had top surgery only, he still has a cervix. Now, he won't automatically receive an invite to the cervical cancer program because his NHS record has now been replaced with a new NHS number that genders him as male, and as such won't automatically receive breast or cervical screening invites. So under these circumstances, it's worth thinking about what information we'd share with Tom and what communication strategies we might want to employ. One of the things that we know is that trans people are at risk of poor outcomes with cancers that are gendered. So by that, we're talking about things like prostate cancers, breast cancers, cervical cancers. And that's often due to that dysphoric reaction to that body part. So in other words, if you were born biologically a male, but are now living as a trans woman, those male gendered parts of your anatomy that you still have may well give you a sense of unease and remind you of that sense of dysphoria. And that might influence you not wanting to take part in the screening program.
But I suppose that the first one, just going back to your previous slide, is I mean, the key issue here is the fact that the NHS and the NHS number is still ultimately completely binary in its recognition of gender.
Yeah.
When medically, that just simply isn't the world we live in, as we know, kind of thing. Is there any work? Is there any anybody kind of lobbying somehow for that to be changed? And why can't we have NHS numbers in 2023 that recognise that somebody is a trans man or woman and may identify as male but still have a cervix that requires screening to be done and things? It just feels somewhat Victorian in nature still.
Oh, very, very much so. And I mean, one of the things that we discussed last time was actually kind of how far behind national legislation, kind of the NHS IT and things catching up with the state of play is. I mean, you're quite right in saying that there ought to be a mechanism whereby a patient can retain their NHS number for that individual, but then be regenerated, because you're probably aware, kind of, you almost essentially assigned a new identity from the point of view of records. I suppose one of the difficulties comes with the fact that within the trans community, you have obviously got people whose gender identity isn't always a complete correlation for what anatomy they have, which I'll sort of go on to describe, really, because obviously kind of you may well have, say, a trans man that sort of gender identifies as a male, but has had absolutely no gender reassignment surgery whatsoever. There will be others for whom, you know, if you're a trans man, you have had, you know, kind of your uterus removed, your cervix removed, your ovaries removed. And I imagine that kind of part of the difficulty is understanding the nuance from one individual to another. But you're right, it's not satisfactory. I think the other difficulty as well is that obviously kind of, if a patient's got a full access to their notes, as many patients will have now, it can be difficult for them if obviously as they're looking through their notes retrospectively, if their pronouns now are different to their pronouns that they were in the past. That could also be a potentially kind of disturbing factor for them. But I you know, kind of recognise it's not ideal, and people at NHS England, there is a sort of a LGBT plus higher group sort of that looks into these matters, are trying to work on this, and some consistency around coding as well, because again, kind of even things like kind of having gender dysphoria as a problem within a problem list is not ideal when it's describing a patient state of play that they may well be very happy with. Do you want it identified as a problem? But yeah, the short answer is there are lots of coding issues and it's not ideal, but people are trying to work to make it more ideal.
So we now have neurodiversity, and hopefully we're working towards gender diversity.
Yeah.
Cool. Sorry, do carry on.
Yep, sure. So as I say, kind of really kind of from the point of view of our sort of trans patients, I encourage them to think that if you've got it, check it out. And as we've just discussed, you know, the automatic screening invites are triggered by the gender record in the NHS record, and the patient or practice will need to proactively invite request appropriate gender-based cancer screening for their trans patients. So certainly for the trans patients that I have, I put a note on the home screen that sort of clearly says what they need, what they don't need. And it's worth bearing in mind as well that if you're a smear taker, you should mark the cytology request if a patient's on testosterone therapy. So for instance, a trans man that still has a cervix, as this can affect the appearance of the cervix epithelium, and it is one for the histologists to be aware of. Zora's got a hand up.
Hi, yeah, thanks, James. It was just a little question about, you know, if somebody's a trans patient and then they receive a new NHS number, then so what happens to all the previous records? So say if somebody has had gender reassignment surgery and then they have a new NHS record, would there be any record of that surgery carried on? Do you know?
My understanding of it is that essentially kind of the old record is archived, but it's possible for the information within the old record to be migrated across into the new assignment. So it won't be like a patient with a new NHS number starts with absolutely no information in their file whatsoever from that day forward.
Okay.
But as I say, kind of one of the difficulties comes with the fact that obviously some of the historical notes entry will have related to them as they were prior to any change in gender. The other difficulty that we have is, again, as we might have touched on last time, is this issue of gender fluidity and the fact that it's not static. So it's perfectly possible for some individuals to feel that their gender is fluid and it starts in one state, moves over to another state and potentially goes back to the other, or they declare themselves to be non-binary, in which case, you know, they may not consider themselves to be gendered in any way. And I think that's where it gets tricky, because obviously we want to make sure that we're respecting the individual's views and wishes, but in a way that's not going to adversely affect our ability to give them the best care, which is where that sort of conversation on a case-by-case basis is probably going to be most helpful.
Great, thanks.
So another case here, Barbara, a 45-year-old trans woman who's been taking hormone therapy, estrogen, for 12 years. Her grandma died of breast cancer, aged 70. So it might be worthwhile sort of thinking about whether you would consider, is a 45-year-old trans woman who's been on estrogen hormone therapy at any higher risk of breast cancer than a cisgendered man? And we remember from our terminology last week, we're talking then about a man who is biologically male and was born with an XY chromosome and male genitalia. So I would consider myself to be a cisgendered man. And also, if we are going to screen her for breast cancer, does she need to be screened any more or less frequently than a cisgendered woman? So what we know is that the lifetime risk of breast cancer is 12% for cisgendered women and 0.1% for cisgendered men, such as myself. Now, a recent Dutch study estimated that the risk of breast cancer for trans women, such as Barbara, was around 4.7%, so roughly a third of that of a cis woman, and that trans women can be appropriately cared for in a standard breast screening program and called from age 50. Though, going back to our previous point, if they are still registered as a male gender on their GP record, it would need the GP or the patient to alert the screening services for invites for mammograms. It's also worth bearing in mind that, as is the case for sort of cis women that have had breast implants, if you're a trans woman with breast implants, that can make the mammography much less reliable, and obviously that would be worth informing the radiographer about. But what we do know is that when trans women do attend for mammograms, it can be quite a gender affirming process for those people. So in other words, they feel that that's a good example of society accepting them as a woman, that they're taking part in the same screening programs as cisgendered women would be. Zora's got a hand up, but I don't know if that's a historical one from last time. It may well be, yeah.
Sorry, historical.
Yeah, no, that's fine. In trans men, so sort of flipping that previous case on its head, it's worth bearing in mind that when you have surgical reconstruction of a male chest as part of the gender affirming surgery, although you're taking breast tissue away, it doesn't include complete removal of the breast tissue, as you're often using some of that breast tissue to contour the chest. Therefore, it's not the same as a mastectomy. So that if any of the breast tissue remains and they are now registered as male, they'd still need referring to the breast screening program and would still need to be breast aware, because obviously if they've had a male gender assigned on their NHS record, they won't be automatically invited to screening, but they've still got breast tissue present, so they are still at risk of developing breast cancer, hence the reason that self-examination should still be encouraged. So just to kind of summarise a little bit about the sort of screening programmes for trans men and trans women in the NHS cancer screening programmes. As I've said, from a breast screening point of view, that for a trans woman, yes, you can have breast screening because we know that you're at a higher risk as a result of the hormone sort of usage. And as a trans man, yes, you should have breast screening because you've still got breast tissue left after surgery. Cervical screening, well, obviously a trans woman has never had a cervix, so they don't need cervical screening, but a trans man that still has a cervix, having not had bottom gender reassignment surgery, will need cervical screening. The bowel screening program is open to people of all genders, so that carries on the same. Obviously, it's not a cancer, but there is a national screening program for it. When we think about screening for abdominal aortic aneurysms, obviously from a vascular risk factor point of view, a trans woman has the same vascular risk factors and vascular biology as that of a cisgendered man, so would be suitable to have AAA screening, but again wouldn't be invited automatically if their NHS record had a female gender. It's a bit more unclear for sort of trans men because obviously from a risk factor point of view and a vascular biology point of view, there isn't the same argument to be made. But again, like the breast screening scenario, again, it may well be one of these gender affirmative screening cases. And I think if a patient was particularly concerned or wanted it to take place with their other peers, I'm sure the screening programs would look on such a case sympathetically. Just having a little think about prostate cancer now, because although there isn't a screening program for it, there are sort of thoughts to be aware of around sort of trans patients. Any trans woman that's taking feminizing hormones and testosterone blocking drugs like the GnRH analogues are likely to reduce their risk of clinically significant prostate cancer as a result of that testosterone suppression. But it's worth bearing in mind that that will also suppress PSA. So if you've got a trans woman who's presenting with new urinary symptoms and you know that that trans woman still has a prostate present, it's worthwhile getting a PSA done, but I would probably interpret the results with caution if you know that they are taking testosterone therapy, because it might affect the validity of the PSA results. So probably one whereby you do a 2-week wait, probably out of caution, and just sort of highlight those caveats that I've mentioned. It's actually some really good information on the Prostate Cancer UK website about prostate cancer in trans patients, which is worth having a look at. Again, kind of worthwhile sort of just thinking about kind of anal cancer as well. As you'll be aware, like in cervical cancer, the HPV can induce anal intraepithelial neoplasia, which is a precursor to anal cancer in the same way that CIN can be for cervical cancer. Anal cancer is much more prevalent in all men who have sex with men, be that gay, bisexual or transgender men. So real kind of vigilance is needed around any man who has sex with a man who presents with abnormal masses, growths, bleeding or abnormal itching. And it's worth reminding you all that the NHS HPV vaccine is available for all men who have sex with men that are under the age of 45 via the Sexual Health Service. So, you know, myself as a gay man, I've had my HPV vaccines via my sort of local sexual health service. It's often one that patients, if they're not regularly using the sexual health services, aren't aware of that they can have. So if you do come across any sort of gay male patients or other patients that you know have sex with men that have sex with men, it's worthwhile just as a quick sort of 20-second kind of reminder to them that they can have this vaccine and it's available. from a practicality point of view, thinking about the bowel cancer screening programme, trans women who've had genital surgery such as vaginoplasty, whereby a vagina can be made out of a segment of colon, might find investigations such as sigmoidoscopy uncomfortable or difficult. And it might be that if you have a patient who's perhaps reticent to go on to have a colonoscopy or things, or is worried about a 2-week wait if they're a trans patient that presents with rectal bleeding, say, it might be worth just exploring that with them, and equally kind of when you're making any 2-week wait referrals, just letting them know about the surgery, because that's obviously something that an endoscopist might want to consider, or they may wish to use other non-invasive forms of imaging. So pause, take a break. That's sort of a little bit of a whistle-stop tour through kind of some cancer screening sort of issues and other sort of screening programs, and how our LGBT plus patients might need a little bit of extra thought when dealing with them. Obviously, kind of gender dysphoria is a huge kind of political hot potato at the moment. And when sort of thinking about what I was going to talk about today, I really wanted to sort of ground that in some work that the GMC have done and some guidance that they've released in the last few months or so. Gender dysphoria is an area whereby I recognise lots of people will have different views. Those views may well be shaped by their own experience, family experiences and things. So I hope what I'm going to present to you now is something that's a fair and balanced view, and also one that the GMC, you know, kind of supports, because I'm aware that there are a variety of views about this, and particularly kind of in sort of the paediatric setting, which I will touch on as well. So as we said last time, gender dysphoria is a term that describes a sense of unease that a person may have because of a mismatch between their biological sex and their gender identity. And many of those patients will have a strong, lasting desire to live a life that expresses their gender identity by changing both the way they look and behave. Many, but it's important to say not all of those, may want to use either hormonal therapy or sometimes surgery to achieve this. It's important to say that it's not a mental illness, and we covered that being removed from sort of the mental health sort of coding last time. But it is important to stress that some patients may develop other mental health problems as a result of their gender dysphoria. So as I said, if we look at some GMC guidance that came about only within the last sort of couple of months or so, they've produced 5 key points on how, as clinicians, we should provide inclusive care to our transgender and gender diverse patients. And they've basically said that, firstly, not everything's about gender. So kind of as GPs and other health professionals, you know, their general health needs are exactly the same as everyone else's, which, you know, kind of goes without saying. It says that we shouldn't assume, we should ask if unsure regarding their preferred names, pronouns, titles, and not that we shouldn't guess about that. We should assume and ask the patients to, you know, kind of provide clarity where we're unsure. And again, we spoke about pronouns last time. It's important to consider whether our patients are self-medicating. Some of you may have come across patients who are turning to self-medication in view of the long waiting times for the NHS gender identity clinic. I think we should try and create an atmosphere where any trans patients that we've got that are doing this feel that they can let us know that in an open way. We can discuss risks and be aware of compatibility with any other medications they may be prescribed. As we've touched on already, we should have a supportive approach to patients' requests to change the gender indicated on their medical record. A number will request a change, but some prefer to keep it unchanged. So again, be one guided by the patient don't let it be something that you impose on patients. And again, as we've just been talking about, to discuss the screening options and be mindful that a change on the gender record may mean they're not automatically contacted by screening programs. So from my point of view, I would say that, you know, regardless of what your personal or social, religious, theological, whatever views are on gender diversity, I actually think that this GMC guidance is helpful, because I think it kind of gives every clinician a framework to think this really should be the bare minimum that, you know, kind of, I think is a reasonable expectation for any clinician to have in their own practice when dealing with patients that have gender dysphoria. So when we come across gender dysphoria in adults, we've spoken in the previous slides about the fact that this is a condition whereby patients have had a long-standing concern about their gender identity. And where we're coming across that long-standing concern and we're seeing evidence of patients making changes to their behaviour and or potentially their appearance, my view is that we should always promptly refer to gender dysphoria clinics, largely because of the significant waiting times, but also signpost to other sources of support for those patients during that waiting period. Now, often in such patients, it might be that you need to refer to your community mental health team as well if you feel that there's coexisting mental health difficulties, particularly where you are concerned as to where the line is drawn between the gender identity difficulties being caused or causal of anxiety, depression, self-harm. All of those things may feature, and I think kind of for us as generalists, it can be really difficult to kind of untangle that. And so from my point of view as a generalist, I think it's about sort of making sure that that patient is in front of the right specialist to help, you know, kind of determine that. From the point of view of self-medication, it's not something that I personally advocate, only because I don't feel that if a patient's getting hold of hormones and things online, they are necessarily going to know kind of the you know, sort of quality of those, you know, kind of, or also they're not going to be having any form of monitoring done alongside it to show that it's safe. And in terms of social transitioning, this is when kind of patients spend a period of time living in their preferred gender. So that might mean that they're sort of changing their clothing, changing their hairstyle, using makeup, that kind of thing. And that's usually a prerequisite to certainly kind of surgery, and often will be an early part of the advice that's given by the gender identity clinic. And again, that's, I suppose, testing the waters of the permanence with which, you know, kind of a patient is happy to continue this journey. And as we've touched on, it's perfectly possible for patients to change their name via deed poll. That can then change their passport, bank details, and obviously then a new NHS number via PCSE can be applied for. So if we think about patients that have been referred into gender identity clinics, they are under their care and they are having hormones prescribed, my personal view is that a shared care agreement with NHS gender identity clinics shouldn't really be different to shared care in any other specialities. You know, kind of as GPs, if we've got a set of rules and a set of guidance to work to, a named person to go to with queries, and a sort of recipe book, as it were, to follow with clear guidance, to me, kind of the prescription of kind of hormones in these adult patients is no different to me, you know, following shared care guidance for a rheumatology patient. So certainly kind of from an NHS gender identity clinic point of view, I think it's very straightforward for GPs to support such patients. Where it gets a lot more complex, I find, is where patients have consulted private providers for their care. And then the private provider is asking for that GP to enter into a shared care agreement with them. And that's where it gets a little bit more sort of tricky, because some of the private providers don't necessarily kind of have named GMC registered specialists as their listed on the prescribing details, and also kind of you get into the difficult territory of, if I'm having, you know, kind of private medicine in one area, is it then for the NHS to be kind of picking up the monitoring of that? So certainly in my current practice, I haven't got any patients that I provide shared care to who aren't under NHS gender identity clinics. I think it's an individual kind of matter, but I certainly kind of think that from my perspective, when I'm working with an NHS service, that provides a lot more sort of safeguards from my own point of view, though it's perfectly possible that other GPs may well form a different view on that. There are some GPs that have chosen to specialise in this area and are confident to initiate prescribing. Again, you know, sort of GMC guidance tells us to, you know, work within our own sort of competency. It's worthwhile bearing in mind that with hormone therapy, obviously trans men will be prescribed testosterone. If those trans men are still having periods and it doesn't suppress their menstruation, then progestins or GnRH analogues can be used to suppress menstruation until they have an oophorectomy as part of any surgery. Now, obviously, kind of if they're still menstruating and still have the organs to carry a fetus, they will still need contraception if they do not wish to conceive. Similarly, trans women will be prescribed estrogen, and again, if this doesn't suppress the testosterone into the female range, then GnRH analogues such as Zoladex may well be used until gender reassignment surgery or orchidectomy. If we think about children now, and again, this is probably even more of a sort of political hot potato than the adults with gender dysphoria. Again, kind of, if we sort of base this around the sort of case, apologies, that we might come across in clinic, I often find that sort of when you have children presenting with gender dysphoria, these can be really difficult consultations, particularly if they're not given a sufficient amount of time. So my own view is that if ever a parent presents, or a child presents for that matter, with concerns about their gender identity, I find it really useful to make sure I've set aside a, you know, kind of a good amount of time to consult with these patients, and I normally find that needs to be at least kind of half an hour. Often what will happen is that you'll be told about, you know, kind of that they are perhaps sort of wearing sort of, if it's a, you know, kind of the parents of a boy who says he wants to be a girl, they'll say that they're, you know, kind of, they've got multiple kind of friends that are girls and wearing female clothing, that sort of thing. I try and ask the child to talk about their hobbies, their aspirations, their fears. If they're sort of secondary age children, I think it's often helpful to ask them if they're attracted to any particular genders, and what are the circumstances and things that make them feel happiest, because it can be a time of difficulty for children. And I think certainly compared to, you know, kind of when I was of that age, obviously kind of there is a lot more information about, you know, kind of the sort of gender diversities and sort of sexual orientation. And I'm sure that, you know, kind of not every young mind finds that as easy to process as others. I often find asking the family how they feel about things, because often it can be a very difficult time for sort of families. They can feel quite alone. They've probably not been in a situation like this with other family members before. And signposting them to appropriate sources of support. There's some really good NSPCC guidance around gender identity, with information for parents, information for clinicians, and information for schools. And I think it's also useful to determine whether you feel there is a role for CAMS as well, because rather like the adult patients, where there can be concern around sort of issues of self-harm, low mood, anxiety, really I think kind of that side of things needs to be bottomed out by a specialist before any referrals to higher authorities can be made. And we know that the teaching profession is, you know, kind of struggling kind of with this issue really, and certainly kind of the lack of guidance as to how they should be dealing with this in the classroom, which I think then kind of perhaps sort of feeds into some of the parental anxiety around these topics. I mean, this was only from a BBC News article a few days ago, that, you know, sort of teachers are aware that they've got transgender or non-binary pupils, particularly kind of in the secondary environment. And you'll have probably heard in recent days about some of the concern as to whether schools should support that social transition. So, you know, kind of the use of the preferred pronouns, the use of the preferred names in the classroom setting, even if that's without parental consent, because we know that these are young people that are at risk of abuse, and that can be abuse both in society and in their own homes. So there can be quite complex sort of safeguarding sort of matters to think about with these patients as well, particularly when you feel that the family aren't in any way supportive of the child's wishes. And to make life even more complicated, as some of you may well be aware, previously all children with gender dysphoria were referred to the GIDS, that stands for the Gender Identity Development Service, which was based at the Tavistock Centre in London. Last year, a senior clinician formed the CAS review in June of 2022, and after that NHS England announced plans to move to a regional model of care for children and young people experiencing gender dysphoria. And as such, at present, the GIDS at the Tavistock no longer holds or accepts a waiting list of patients for specialist assessment with children with gender dysphoria. And all the new referrals are being sent to Arden and Gem's clinical support unit on behalf of NHS England. I haven't yet really seen what's happening with any of those referrals. They seem to be sort of going into a, you know, kind of a basket somewhere, but I'm not entirely sure what's coming out at the other end of that. But what is interesting is they've made a point of saying that the new service will accept referrals from GPs, CAMS, paediatrics, schools, social care, and relevant voluntary sector organisations. So that might be support organisations that work with sort of children and families experiencing gender dysphoria, but they won't take self-referrals. All the details and referral guidance about this new process are on their website. But one of the things that I suppose did strike me was I think it's actually quite a positive thing that the new service is going to be taking referrals from a much wider scope of professionals, because I often think that as GPs it's impossible for us to really kind of get a sense in, you know, 30 minutes or so as to what you know, kind of this child's life is like. And I think kind of knowing that referrals can come from other organisations that possibly have a far greater insight into the child and how they sort of view the world and been experiencing life over the last few years is probably a good thing. And certainly from my perspective, whilst, you know, kind of I would certainly support appropriate referrals, I think I'd be really encouraging other agencies that are involved in those children to be either making those referrals into this new body or certainly contributing evidence alongside my own, so that I kind of felt that a really holistic view was being presented of these children. So if we think a little bit now about fertility support, and this is fertility support across the whole of the LGBT plus population. Again, as GPs, this is something that perhaps we get involved with, and certainly I've had, kind of many consultations over the years where LGBT plus patients might approach us for support when they're wishing to become a parent in any way, and that might be through IVF. So certainly I've had female same-sex couples or even single women who I remember certainly a case where a woman came to me who said that she was asexual but still wished to become a parent, will approach us for help with sort of IVF and through the down the fertility routes. Obviously, you'd need to check with the kind of current ICB criteria as to what meets NHS funding, particularly in patients who may well be in a same-sex relationship now, but might have had heterosexual relationships previously that have resulted in the birth of children. Increasingly, I find that more and more of our LGBT plus patients are choosing to go down the adoption and fostering route, and obviously might approach their GP for medicals. We have had in my practice some patients, particularly male same-sex couples who've had children via the surrogacy route. You'll be aware that whilst surrogacy isn't available on the NHS, it is legal in the UK, but it's illegal to advertise for surrogates, and surrogates cannot be paid in the UK, though obviously that's a different picture if surrogacy is undertaken abroad. And some trans and non-binary patients may choose to look at preserving their biological fertility by freezing either their eggs, sperm, or even embryos prior to starting hormonal treatment. And certainly, kind of on the rare occasions that you might have a trans patient sort of want to talk to you about that, the Human Fertilization and Embryology Authority has some useful resources on that. So just to sort of, oh, sorry, Ben, yes.
Thanks, Joe. So it was just to highlight actually the cryopreservation of gametes is actually, there is a policy on that, an ICB policy on that, which has just undergone a slight revision. So that is part of the wider IVF policy. So if you do get people in that situation coming to you, it's worth going to the ICB documents on the website to have a little look at, as well as the national stuff, because there is a local stance, and we've tried to bring it more in line with the updated national stance recently. So
good, and that's really good to see that kind of even on that sort of local level that kind of it's being borne in mind. I just wanted to finish, because I'm conscious that we're coming up to the hour's time, just by having a little chat about some sexual health promotion areas, particularly around post-exposure prophylaxis, pre-exposure prophylaxis, and HIV. We know that sexually transmitted infections continue to rise, especially amongst men who have sex with men. Large increases in chlamydia and gonorrhea. That's potentially driven by sort of better diagnosis, people being more sort of prepared to go to sexual health clinics for testing. But we also know that there's been some big behaviour changes, such as increased partner numbers, M-sex, so the use of drugs to facilitate kind of sexual encounters, and also kind of wider group sex facilitated by social networking apps, which obviously was not the case 50 years ago or so. From the female point of view, I think there's often quite poor awareness around the sexual health needs of LGBT plus women, and we know that sexual screening rates amongst those women remain low. We know that women who have sex with women have higher rates of bacterial vaginosis, and young bisexual women report riskier sexual practices, more chlamydial infections and unplanned pregnancies and terminations than heterosexual women of the same age. I think kind of really kind of one of the success stories around sort of LGBT plus health, and those of you that kind of watch the Channel 4 series, sort of It's a Sin, that was all around kind of the growth of the AIDS sort of pandemic in the 1980s. You know, kind of you really do contrast that with kind of the state of play today, that, you know, kind of massive reduction in new HIV diagnoses since 2015. And that's been a result of a combination of strategies around prevention. There's a much greater awareness and uptake of testing. Some of you might sort of promote in your practices the sort of Give HIV the Finger, the National HIV Testing Week, and, you know, HIV testing's a lot easier than it used to be. Similarly, post-exposure prophylaxis is widely available. That's medication that's prescribed after a risky sexual contact for 4 weeks, and we know that if you take post-exposure prophylaxis for those 4 weeks, it can reduce the risk of developing HIV by 80%, and that can be obtained either through A&E or sexual health services. You may well come across patients in your own practices who take what's called PrEP, so that's pre-exposure prophylaxis, and that's medication that provides almost 100% protection from contracting HIV from a HIV positive individual, and that can be taken daily or event based. So kind of some people are having lots of sexual contacts might choose to take it on a daily basis. Other people, if they think they are likely to be having riskier sort of sex where it's more likely to contract HIV, they might use it on a as and when basis, and that can be supplied by the sexual health services. The other thing to bear in mind as well, patients are just taking really effective antiretroviral medications. The U equals U campaign, some of you might have come across, whereby undetectable equals untransmittable. In other words, if their viral loads are so low with the medication that they are taking that they're undetectable, those HIV positive patients will not be able to transmit HIV. And I think that's really helping to kind of help with the stigma around HIV diagnosis that previously existed. I think it's probably fair to say that, you know, kind of HIV has gone from something that you die from to die with, really. And really, I think kind of it's amazing to think that kind of HIV kind of will be managed like any other sort of chronic disease, you know, sort of asthma or something like that, wildly different to, you know, what was the case 30, 40 years ago. And finally, just because obviously this gained a little bit of traction and prevalence sort of in the last sort of 12 months or so, I thought I'd just give a bit of an update on mpox, previously referred to as monkeypox. Men who are gay, bisexual, or have sex with other men and have multiple sexual partners or participate in group sex or attend sex on premises venues are at much higher risk of contracting mpox and are currently eligible for an NHS vaccination. Staff who work in those settings are also eligible for the vaccination. However, the NHS mpox outbreak vaccination programme is going to be ending soon. And to get it, you'll need to have had your first dose by the 16th of June 2023 and your second dose by the 31st of July 2023. After that, the vaccination programme is going to be stopping. So certainly in my own practice, I have put a thing on our sort of social media channels just to highlight that, you know, if patients who feel they fall into any of those categories haven't had their mpox vaccine yet, they need to get a wriggle on if they want one while it's still available on an NHS basis. So just to close then, hopefully kind of during the hour, I've really sort of tried to kind of cover those GMC principles with a bit of added, you know, kind of information around those. So hopefully kind of as a result of this session, you'll be aware that cancer screening should be targeted appropriately for LGBT plus people, particularly where they might not be automatically recalled. The GMC does set principles for how all clinicians can provide inclusive care for transgender patients and those experiencing gender dysphoria. The pathways for specialist referral of children experiencing gender dysphoria are changing. As GPs, we might be approached to offer fertility support to our LGBT plus patients, and in our day-to-day practice, we might encounter patients using PEP or PrEP to reduce their risk of HIV. And as I say, the next session is on the 31st of August, where we'll be looking more from a practice basis and how we think about looking after LGBT plus staff in primary care. As ever, I'm more than happy to take any questions or comments now, or feel free to email me after the event, as I know a number of people did last time.